about a topic that I feel is a key component of patient-centered healthcare, and that is effective communication between patients and healthcare providers. As I hope all of you have been experiencing in your clinic visits, healthcare has been moving from the unidirectional approach, where the physicians would just explain treatment plans, instead of just physicians explaining plan and treatment options, now we want to have this bi-directional patient-centered view. So we've been emphasizing shared decision-making, which allows effective communication between the patient and the doctors, thus empowering patients to come up with plans that are best for them. So as I mentioned, few decades ago, hopefully a lot of you have been experiencing in your clinic now that we are really focusing on shared decision-making, because now we know that essentially by educating the patients and then by patients to actually talking about their preferences, their questions, we can empower them and come up with the plans that are just right for them, especially in the setting of us now having multiple treatment options. There's not necessarily like a right option and for everyone. So we really want to find the option that is best for you. We recognize that clinic visits are only 20 minutes, 30 minutes, or 40 minutes, but your disease does not stop there. So my goal, and a lot of, I think, physicians' goals are, when they're in the clinic, I want to make sure that I communicate all my thoughts with you, and you know about the disease and about what I'm thinking as much as I do. That way, you're empowered to know exactly when you go home, what symptoms you want to look for, how you're going to communicate with the doctors. And that way, hopefully, it empowers you to take charge of your disease and also alleviate some of the stress that you have living with a chronic illness. So through this talk, I'm really hoping to offer empowerment through effective communication with your gastroenterology team and also allow for enhanced shared decision-making. The outline of the talk, so we're going to start talking about how you want to prepare for your clinic visit. We're going to talk about discussions during clinic visit, and what essentially shared decision-making is. We're going to talk about symptom review, treatment options, as well as treatment goals. Next, we will talk about communication with your team in between appointments. Also, we want to talk about preventative care with not only your IBD physician, but also with your PCP. And I want to highlight mental health because a lot of times when we are seeing our gastroenterologists, patients may not actually communicate about mental health, but we are here and we recognize that, IBD is a chronic disease and it can affect your mental health significantly. So that is actually part of things that we want to discuss with you. And then finally, I'm going to offer some patient resources and I'm going to end with some Q&A. Hopefully we're going to have a few questions at the end so that Dr. Dueker can address those, and Dr. Dueker and I can address both of them. So preparing for your clinic visits. So key thing is here, I want to make sure that people get an understanding of what they need to look for when they have their disease. Because oftentimes when you get diagnosed with IBD, a lot of patients are not as interested in pathophysiology, but they want to know how it affects them. So what are the GI manifestations? What are the extraintestinal manifestations of IBD or inflammatory bowel disease? It could be UC or Crohn's or indeterminate and anything in between. And it's very important. So right before your clinic visit, to know what symptoms to look for, so in order to actually think about them and talk about them to your doctor. So we want to talk about, actually, it would be important to write down your symptoms, including their frequency and severity since last visit. Also, it would be important to talk about essentially, maybe if it's too overwhelming, just talk about your symptoms just a week prior and write those down. So I'll talk about those briefly. And finally, there are some questionnaires that you can utilize in order to help you to write down your thoughts and your symptoms. So what are the symptoms that one would expect from having IBD? So, of course, IBD is a disease that affects your gut system. So there are some GI manifestations. Most patients are familiar with these symptoms, so diarrhea, and it could, it could be accompanied by blood or mucus, but usually that's more seen in ulcerative colitis compared to Crohn's. Fecal urgency and or incontinence, tenesmus, that sensation that you have that you need to pass stool even though your bowels are already empty. Abdominal pain and cramping, you see that a lot. But does that mean it's all because of your IBD or something else? So we'll talk about that as well. And finally, some patients may experience dysphagia, which is the term that describes as a medical term for difficulty swallowing, and they may have nausea and vomiting if Crohn's disease involves the upper GI tract. So some of the general manifestations of IBD, so fatigue is a symptom that you want to keep track of because that could be because of your IBD, weight loss, malabsorption. So if you feel there's, your diet has changed, raise that. If you are avoiding some particular food and you feel like, hey, I don't think I'm getting as much nutrition as I want to, that's something that you want to actually, before your clinic, write that down. And finally, if you've ever had any fever, if you feel like overall, like if you've had infections, anything systemic that is going on. Most importantly, I also really want to highlight the extraintestinal manifestations, because with the GI manifestations, they're like diarrhea, abdominal pain. People are aware of that and they keep track of that. But I also want to make sure that patients, all of you guys, are aware of the extraintestinal manifestations of your IBD. So liver problems. So if you feel that your skin looks yellow, itchy, you want to keep track of that. If you see any skin lesions, you also want to note that they can come and go. And in this day and age that a lot of people actually have cell phones, it's great. Just take a picture of your skin. And then you can send it to your doctors. And we'll talk about how to communicate after in between your visits as well. Any eye problems, any oral ulcerations, any joint pains. If you've had any problems with blood clots, you feel like you have had difficulty breathing. If you've had kidney stones, actually that is part of your IBD. You may have, some patients may experience increased risk of having kidney stones. Also, they may have respiratory problems. So as I mentioned, there are a lot of symptoms. We talked about, GI manifestations, extraintestinal manifestations. So it's really hard to keep track of all of that, but this is kind of all of the symptoms that I would like to address in each visit. And I think that's pretty universal for most doctors. I wanted to put that here. So at each visit, I really want to know about the stool frequency, consistency, urgency, abdominal pain, cramping, any changes in appetite, diet, unintentional changes in weight, eye issues, skin issues, rash, mouth ulcers, perineal disease, changes in your energy level, fatigue, recent antibiotics, NSAIDs, mood, mental health, as well as your work-home environment. So we'll talk about that as well. So if you want, you can just take a screenshot of this and keep that in mind as you are thinking about your symptoms before your clinic visit. So in addition to the review of symptoms, be prepared actually to discuss, we want to discuss about the lifestyle adjustments you've been taking. Change your diet drastically. You feel like you know all the bathrooms on the way to work because you've had a lot of urgencies. There are gatherings you're avoiding because you feel like if you eat food, everything goes right through you. So, keep track of those as well. Anything that affects your lifestyle, we want to know, especially we know if it's because of IBD, because again, we recognize that IBD is a chronic illness and it can change your life drastically. And our goal is to communicate the best with you in order to make your life as best as we can. Recent changes in your health. If you've ever had any recent infections, document that. And then so that later on when you come up to your clinic, say like, oh, by the way, 3 months ago, I had, COVID, or I had sinus infections and you had to take some antibiotics. Antibiotics can change the gut microbiome and it can affect your symptoms as well. So we want to know about antibiotics. NSAIDs. So we really want to know if you ever took ibuprofen, over-the-counter pills, any herbal supplements, share those with us. Keep track of those. And mental health. document about your mood, how much you're thinking about your Crohn's. Does it really causes anxiety for you? And do you feel like maybe the anxiety is making your Crohn's or UC worse? So we want to talk about those. And then finally, if, this is just essentially how you want to prepare for each visit, but if it's your first visit, ensure your medical records have been received. Prepare a timeline of your disease. So oftentimes we get essentially a lot of outside medical records, but I always like to hear the story from the patients, because errors happen in documentations, and I feel like the patients are the best and most reliable source. So I want to hear the story from them. So it's great if you have a timeline already prepared. So when you were diagnosed, what medications you've tried, if you've ever had surgeries and what surgeries you've had, that's extremely helpful and and allows you to get the most out of your visit. Also, if you've had any providers from outside of the healthcare system you're being seen, it's great if you can bring their cards or contact information with us, because we recognize that IBD requires a multidisciplinary field and team. So we want to make sure that we have contact information, all of your providers. So we talked about how to actually prepare for your visits. So during your clinic visits, so if you've written things down, bring them with you. And also take the time you need to talk about your symptoms. So please don't be embarrassed about giving details, as your doctor is there to help you. Also, during the visit, I encourage people to take out their phone or even have a notebook or a piece of paper that they can write down things that we're discussing. Because we now know, I think even outside of the medical field, when you have a meeting, we all retain about less than 50% of what was really discussed in that meeting. So it's important to actually feel free to just write down exactly what's going on, and that allows you to remember things better. Also, you can bring someone to the visit to help you remember more. We love it when you have your partners there, your significant others, family members there, or even friends, because they can remind you of things that you may have told them in the past about the symptoms that you can share with us, but also they can help you to remember things that we discussed during the clinic visit. So we always encourage that. If there's someone you want to bring, that would be great. So we just talked about, we spent a lot of time about the symptoms, because that's what I want you to understand really well, and to know exactly what symptoms to keep track of, and in order to show up to your clinic visit and share that with your doctor, so your doctor can come up with the best plan for you. But of course, during each visit, there are other things that you and your doctor should really talk about. And I divided into 3 types of clinic visits. One is your initial diagnosis. The other one is your disease, when your disease in remission. And the other type of clinic visits would be when you have a relapsing disease or disease that is refractory to medications. So when I talk about the initial visit, I don't mean just your first visit, the initial diagnosis. I don't mean just the first visit, because when you're diagnosed with IBD, it's a chronic illness. It can be very overwhelming. Nowadays, people can Google and search online about their, about Crohn's, about when they're diagnosed with it, or about ulcerative colitis. The course varies for patients. Some patients may do really well. Some patients may, fail multiple treatments. And it can be very overwhelming and scary and stressful to be first told that, hey, you have this chronic disease. So during these visits, it may take 1, 2, 3, multiple visits for you to actually really understand the disease course and manifestations. Take the time, ask your doctor, what are the symptoms that I'm expected to experience? What are the symptoms that are alarming? What are the symptoms that if something's happening, that I should call or go to the emergency department? And what essentially, with the current treatment options, what's kind of the long-term picture for me? So really, in the initial diagnosis, when you have your symptoms, bring them. talk, and we want those symptoms to be for every clinic. But in your initial diagnosis, really take the time to actually ask questions to understand your disease. Because when you know your disease, hopefully it can decrease the stress. And as we'll talk about it shortly, we know that stress can contribute to flares of your symptoms, and also the flares of symptoms can cause stress. So if you know what symptoms you're experiencing, what are the alarming features and what's more reassuring, that can hopefully offer peace of mind and decrease your stress. Also, during the initial diagnosis, that's when you are really starting to talk about shared decision-making, mainly treatment options as well as treatment goals. So treatment options. You want to, so after, talking about your disease and getting a better understanding of your IBD with your doctor, you want to talk about what are the treatment options that are available to you. You want to talk about, what's their efficacy, and also what are the potential side effects that you may experience? What are the common side effects? What are the rare side effects? What are the reversible side effects? And some things that maybe not reversible. So it's important to ask those questions. Goal is to minimize short and long-term toxicity of therapy, of course, and offer the medication that we feel has the best efficacy to treat your disease. Also, it's important to express your preference for administration route. Some people like pills, some people like suppositories, some people like infusions, injections. And then ask for alternative medical, surgical, or endoscopic options in case of medication failure, adverse effects. So luckily, the toolbox for IBD treatment has been evolving over the last few years, and it's been actually, we've had many new treatment options that are available to patients with Crohn's or UC. So about 50 years ago, there were mainly only 2 medications. And then now you see that just within the last 5 years, we've had 5 new medications that have been added to the IBD treatment toolbox. But mainly with the subclasses of medications are the aminosalicylates, those are for instance, for UC, steroids, immunomodulators, biologics, as well as small molecules. Key thing is, there's of course, algorithm. Different societies have put certain guidances based on extensive research that, when you report your symptoms, and also some of the objective findings of, if you had a scope, your CT scans, your lab values, your doctors already can think about the potential treatment options for you. But as I mentioned earlier, now that we have a lot more options, there's not necessarily just one right option for everyone, with that essentially following the guidances and the research. We really want to be able to do shared decision-making. We want to go over the medications with you, the treatment options, and see among the ones that fit are recommended for you, which one is the right one for you. If you like pills more than, injections, if you are essentially, your doctor thinks that both of them are options, express that. So like, I would rather take the pills, small molecules or pills. If you don't feel like injections are good, you don't like needles, you don't want to administer every couple of weeks, you don't want to inject anything. We have infusions. So within the SEM classes, there are like medications that are being offered, as injections or infusions. So by essentially thinking about, what route of medications you like, that, you can allow for more effective shared decision-making. And these are, so similar medications are for Crohn's, except, not the small molecules. We're still waiting for FDA approval for them. So once you talked about treatment options and you pick a treatment, you want to actually come up with your treatment goals with your doctor as well. So what do I mean by that? So you want to talk about, once you start a medication, what's the endpoint goal? Are you expected to see improvement in your symptoms? But if and name the symptoms that are really worrisome for you, and what you expect them to improve. Also, quality of life is important. You're just diagnosed with IBD, and I'm sure it causes a lot of stress, and it can affect your quality of life significantly. Name the things that you're worried about. You don't want to run to the bathrooms. You want to be able to go out to gatherings more. And that, if that's part of your treatment goal, discuss that with your doctor. Healing of inflammation. All of us, that's a priority for us. So we know that our end goal is to make sure that the inflammation is subsided. So then the goal would be with you to discuss, do we want to do colonoscopy? Do we want to do abdominal imaging? Do we want to do stool studies or fecal calprotecting? Set those goals with your doctor. So you have an expectation of like, hey, this is when then I know that, the treatment is working because X, Y, and Z, and how you're going to find out if you've had some steroid, if you've had your healing of inflammation. And then finally, patients who have been steroids for a long time, they come for a second or third opinion, and their goal is just to be off of steroids. And that's perfectly fine. So it's important to set goals as you come up with the treatment options. One thing that I wanted to really emphasize, and I feel a lot of patients feel like they need to make a decision by the end of the clinic visit, that's not so. You actually do not need to make a decision at your clinic visit. Ask for more time for if needed. And also learn what the next steps are. So when your visit is done, so when you're setting your goals, indicate how you want to communicate your progress or express your concerns after your appointment. Some providers would like to actually receive phone calls. Some people like electronic messages or patient portals. Ask them what's the best way. Ask about anticipated response time, so you're not worried about if nobody's getting back to you in 1 or 2 days. You're not worried. And also, that if it's something urgent, ask them about, do you feel like you will get back to me better if I give you a phone call compared to if I send you a message? So it's important to actually communicate that and ask those questions. And then how often you want to check in with them already, because your clinic visits, we're going to say, let's follow up in 6 months. But as I mentioned earlier, your disease does not stop there. Things can change. We know that you walk out of the clinic office. Me as a patient, has happened to me multiple times, and it has happened to a lot of my patients. You walk out, the moment you close the door, you get in your car, you just remember, oh, I forgot to ask about X, Y, and Z. It's okay. You can always reach us and message us, and set that expectation already with your doctor, saying like, hey, if this happens, how am I going to communicate with you? Also, you may have not had any symptoms. You documented for the last week, you did the perfect preparation for your clinic. You didn't have any blood in your stool. You didn't have any of the symptoms that we just reviewed. 3 days later, you have those symptoms. As I mentioned, review with your doctor. What are the alarming symptoms? When do if they want to call, when should you call them if you have some symptoms? Also, when the symptoms and that are maybe more benign, or maybe kind of more like moving up and down without much serious consequences, it's more reassuring for you. So learn about those things and know how to communicate that with your doctor when these symptoms come up. After the visit, also, now with the electronic records, a lot of healthcare providers, they allow patients to see their clinic notes. So I encourage everyone, after a couple of weeks of your visit, log on and see if you can see your clinic note. And that way, it reminds you of everything that you discussed with your doctor. Also, when you call, a lot of our nurses would like actually when the patients call. And I agree, because it's best when the patients call instead of family members, because A, it empowers the young adults or the patients. And B, by just talking to the patients, we get a better history and we can understand the symptoms better, and allows us to come up with plans better in between our visits. So I'm hoping you had your initial diagnosis, or you came for your second or third opinion. You had a great discussion with your team about treatment options, treatment goals. And after 6 months to a year, you're in remission based on the goals you've set up with endoscopic remissions. The quality of life has improved. So what would you want to discuss in those visits? We want to talk about preventative care. Patients with IBD now essentially live as long as patients who don't have IBD. So long-term preventative care is important, that you want to talk with your PCP as well as your IBD doctor, gastroenterologist, but also there are particular things about IBD patients that we want to keep track of, especially if they are on some biologics or medications that decrease your immune system. So we want to prevent any infections or cancer. So we'll talk about that. When also your disease in remission, it's okay at that point, revisit goals. In your first session, you talked about my goal, for instance, your goal at the initial visit was to have endoscopic healing. But now you notice that even though you have endoscopic healing, you have joint pain, you're very fatigued, you still have intermittent diarrhea. So reset your goals. Hey, I think, can we talk about these other symptoms that I'm experiencing? Also, when it's important to talk about mental health and sexual health. And finally, about symptom management and the gut-brain axis, which we'll talk about right now. So for IBD preventive care, so all IBD patients are recommended to receive influenza vaccinations annually, as well as pneumococcal, so pneumonia vaccination, and COVID-19. Shingles or Shingrix vaccination is safe. A few years back, some people may have, if they have been diagnosed with IBD like a decade ago, they probably remember that shingles was not a vaccination that was offered to them. So now we want all of our IBD patients to get Shingrix. General population, they get it over the age of 50. We recommend, and people that have any chronic diseases or autoimmune disorders, actually, they're recommended to have it over the age of 19. So if you've had, even if you've had, so as you know, with shingles, it can be very painful, can affect part of your skin, and as essentially reactivation of the chickenpox that you may have had as a child. Other inactivated vaccines are safe, so pending, what other your doctors, and your other problems, your PCP may offer other vaccines. So remember that essentially inactivated vaccines are okay. Live vaccines, we like to avoid them when somebody is on immunosuppression therapy. So if they're on biologics, they're steroids, or an Imuran, or like immunomodulators, we want to avoid that. So ideally, you want to kind of be off of those and get those beforehand. And then talk about your IBD doctor. So if your PCP wants to try a new vaccine, check with your IBD doctor to see if it's okay for you to get that vaccine. It's important to get yearly skin examination based on treatments. So we know some treatments, for instance, since I have Imuran listed here, azathioprine, that can affect risk of skin cancers. So it's important to get annual skin treatments. The big thing that we know that patients with IBD at risk for is colorectal cancer screening, colorectal cancer, because the inflammation in your colon, if you've had that as part of your ulcerative colitis or as part of your Crohn's that involves your colon, can increase the rates of occurrence of colorectal cancer, almost twice as much as the general population. So you want to talk about how frequently you need colorectal cancer surveillance. And then also, it's important to consider timing for your DEXA or bone scan to evaluate for bone density, especially if you've had steroids. It's important to get a DEXA scan to make sure your bones, you're not getting osteoporosis or like weakness of your bones. Mental health and sexual health. If you feel you have anxiety and depression, please share that with your doctor, because, and we'll talk about it shortly, why it's important. We really want to hear about that. We want to know how we can treat your disease in order to help with your anxiety and depression, especially if you feel like your anxiety and depression stems from that, but also anxiety and depression can contribute to your symptoms. Raise any concerns about your sex life. I feel like patients are shy about that, but I just want to reassure everyone here that as gastroenterologists, we are prepared to discuss this. because we know our IBD patients, if they have perianal disease, if they have ostomy bags, if they're teenagers or young adults, they have a lot of questions, and they may have a lot of insecurities when it comes to sex life. You diagnose with it, or you have a new ostomy. So please let us know, because there are a lot of resources and ways that we can help you if you have any problems in your sex life. If you are getting ready, if you're a young female, and you are thinking about family planning, you want to get pregnant, we are also prepared to discuss that. So this would be something that keep track of when you're disease in remission or even active disease and you're young and you're thinking about this. Let us know. We want to know if you're planning a family and you're planning on getting pregnant. And then finally, we can always refer you to a therapist or psychiatrist if we need to. So here we talked about symptoms. So we talked about, the scenario I said earlier, your disease in remission based on you did your colonoscopy, the inflammation is gone, but you still have a lot of symptoms. So you want to keep track of those and bring that up to your doctor. So list your symptoms, prioritize them. I love it when patients come in and they say, what I'm most bothered by is my nausea. What I'm most bothered by is the fact that I have really bad urgency or incontinence. So it's great when people prioritize, these are the top 3 things that are bothering me, but also I have all these other symptoms as well. So we can start focusing on targeting and addressing those symptoms to make sure that, we are improving your quality of life. So you may be experiencing symptoms even though you don't have any inflammation anymore. And these symptoms could be related to your IBD. So we talked about joint pain. That could be, due to your IBD. Your gut is healed, but inflammation is ongoing in your body. And then the joint pain is maybe perhaps due to your extraintestinal manifestation of your IBD. But also it could be because of other diseases. It could be due to the gut-brain axis or dysregulation or irritable bowel syndrome. So this is a new emerging field. So gut-brain axis, the way I think about it, imagine, so you've had inflammation in your gut, and so the fire alarm was on. Your body was saying like, hey, my gut is on fire, be aware, seek treatment, talk to your doctor, take care of this. So now you've already done all this stuff. But then for some people, we know about 30% of patients have this gut-brain axis dysregulation, that when 30% of patients, they do have this gut-brain axis dysregulation. And what that means is that fire alarm never goes off. So there are some symptoms that you may still experience even though you don't have any inflammation. We can address that. We know there are these neurotransmitters that we can target them in order to actually calm the nervous system in your gut. We also know that stress plays a huge role. As I mentioned, stress can cause flares, but also flares can cause stress. So it's important to target your stress and anxiety as well. And some of the neuromodulators can actually affect both. So that's why really, even if your disease in remission, it's important to keep track of your symptoms, because perhaps there's, we can do treatments that we did not talk about during your first visit, because they're not your necessarily classic IBD or inflammation treatments, but there are treatments that are developed to target this gut-brain axis dysregulation. And then lastly, unfortunately, we know that some patients, even if their disease has been in remission, they may have relapsing disease. Or the patients, after we see them the first time, we try a treatment, after 6 months or a year, they still are not getting any better. So that's a different type of visit when we want to really focus on relapsing disease or disease refractory to medication. So same as initial diagnosis, we want to delve right back in and really talk about your treatment options and treatment goals, and also talk about surgical versus medical. This is a very busy slide. The only reason I have this on, just to emphasize, there are so many medications. So many different treatment options in this day and age that we can offer you. So if you are failing a medication, so based on, you're feeling empowered, you know what symptoms you're having effective communications with us, we will find the right medication for you. Key things that everybody's worried about. At the end of the day, if everything fails, is surgery something that you need to, consider? And I want to ease your mind. Surgery is a treatment option. We know that 25 to 35% of patients may not respond to treatment and may require surgical intervention. The 10-year risk of surgical resection for Crohn's is nearly 50%. And many patients with Crohn's ultimately require surgical intervention in setting of bowel obstruction, abscess, or perforation refractory disease. These numbers, we're hoping that will just keep reducing as we are coming up with new medical interventions. But so surgery is something that if you have Crohn's, for instance, now there's a 50% chance in 10 years you may need surgery. Could be very small, just a resection, taking part of a small bowel out, or it could be a larger, surgery like for ulcerative colitis, taking the colon out. I encourage everyone to, how you have this open communication with your gastroenterologist, to actually have open relationship with your surgeons. So whenever, even you are undergoing medical treatment, ask if you want, you can meet with the surgeons that are part of the team. So you get to know them just in case in 10 years you need surgery. Doesn't mean you need to have surgery now. And a lot of surgeons are really open to that. So ask if you could meet with the surgeons, be open to meeting with surgical team, discuss surgical options. If you have stage surgeries, pouch, future medication, surgical treatment options, risk and benefits, and also prepare based on what you talk about your surgeons, then go back and talk to your gastroenterologist, adjust goals now that you are more empowered and you have more knowledge. Talk about if you want to change any medications, and ask for resources, because patients with IBD, they're, they are very supportive of each other. And we see that, we recognize that, we appreciate that. And there are a lot of good resources out there. So of course, Crohn's and Colitis Foundation is fantastic. There are local in-person and virtual support groups available to you. There are Facebook groups available. And then the rest, these slides, this slide actually was provided to me by Ms. Tina Aswani Prakash, and who's actually the co-founder for Own Your Crohn's. And she offered these resources that she works with Crohn's Colitis Foundation to offer their patients as well. So United Ostomy Association of America. So it's a local in-person and or virtual support groups for people who have ostomies. Girls with Guts, large private Facebook group. As I mentioned, a lot of young girls may feel, they want to plan for pregnancy, or they're worried about their ostomies. They want to talk about their challenges with great support groups. And then also Improved Care Now is a large community for pediatric IBD patients. And then South Asian IBD Alliance as well. So just to kind of review what we talked about. So I really think by having effective communication, we really can, your team has the best chance to provide the right treatment for you. And it starts with you before the clinic visit. So we talked about how you can prepare for your clinic visits, keep track of your symptoms in between clinic visits, keep track of your symptoms maybe just 7 days before if things are doing well. Write things down, do questionnaires that are available online, like such as the one from the Crohn's Colitis Foundation website that I showed you, but ask your doctor, is your questionnaire he or she wants you to have filled before the visit. We talked about the different, discussion points during each visit, really highlighted treatment options and treatment goals. This is where the shared decision-making happens. You really talk about the symptoms you have, what are the options that you have available to you, know the risk and benefits, and really talk about the goals, set goals. If you want to walk away from this talk, the most important thing I want to emphasize is please set goals with your doctors. It's a team, it's a patient. So we are really focusing on patient-centered healthcare. You are center of the team, and all of us are here to help you to come up with a plan for you. So set up goals with your patients, with your doctors. Communicate in between appointments. It's important. We want to hear to see how you're doing. Don't wait 6 months. really preventive care is important. IBD patients are doing great now, same life expectancy. So we want to make sure, as patients that don't have IBD, so we want to make sure that, your, cardiovascular disease rate is okay. You don't have, high lipids. So think about those things, but also think about the preventive care specific for IBD. We really want to talk about mental health. We know IBD is a chronic disease. It affects your life. So as part of our training, we welcome patients to talk about their mental health. And then finally, we can end with some Q&A. So I'm excited to see what questions you have for Dr. Dueker and I. So I really hope that we have empowered you by this talk to have effective communications with your gastroenterology and have enhanced shared decision making. With that, I want to thank you for your attention. Hopefully you've stayed here for the last 40 minutes and you got something out of it. But again, I understand we all walk away with only 50%. So just remember this talk, I really want you to feel empowered. You are the center of the team and you set the goals. We want to come up, let us know what goals we want to reach and work with your team to have shared decision making. All right. Thank you so much. And Dr. Dueker, I'm excited to see what questions we have.
Dr. Ghaffari, fantastic presentation. Thank you for taking the time and doing such an excellent job. I wanted to encourage everyone, you might see some questions in the question and answer section of our Zoom webinar here. I would encourage you to type your questions in. And I realize that I clicked one question is answered, but I will get back to that question. It's not technically answered. So I had one of my own that I wanted to bring up to you. And this is, what if there's some sort of strain in the doctor-patient relationship? So the patient is maybe frustrated with an interaction with somebody, the physician or somebody on the healthcare team. What's your suggestion about how maybe to best handle that situation that could potentially result in the best outcome?
Wonderful. And again, with any interactions, personality is there, and also things can happen, errors can happen. It's really important. I mean, I keep talking about communication, effective communication. With that, also, if you are not satisfied or there's a strain, as you put it, with the team, name your feelings. Talk about if you're frustrated with this or if you feel there needs to be some improvement. I'm sure your doctors, your team, the nurses, everyone would like to know if they're not doing their best to address your questions. So I think the first step is to really let us know if there is something that we're doing wrong, or it's not, essentially our style is very different than yours. When it comes to shared decision making, we can talk about what's the best way for us to communicate and approach things. So I think first thing would be to really address that, talk about what's going on. Second, really give it time, give it 1 or 2 sessions before you kind of give up, saying like, hey, I don't think this is the right team for us, because then, as human beings, we can always improve, but it takes time because, our habits can change, gradually. Give maybe 1 or 2 times, or depending on how you feel, what your comfort level is, see as you address your concerns, if those concerns are being met and answered. And finally, if you feel your doctor is not the right fit for you, it's absolutely fine to, Crohn's Colitis Foundation, American Gastroenterology Association, they have a lot of list of doctors. You also can reach out to the patient resources and ask if they recommend a physician or provider that they like. And it's okay. We see this all the time. We recognize that. I think second, third, fourth opinions are always welcomed. Again, you're the center of the team, and it's important for you to find the team that works for you. But please let them know if you feel like you have any frustrations. Open communication is key.
Yeah, that's a really fantastic answer. And I really like that you said to, you recommended to sort of air the frustration and then see what the response is, because the response could be very positive and there's a lot of growth. But if it's negative after that, then you sort of know, that's maybe that's a sign that maybe things aren't going as well, or that you may want to consider that second opinion. So, but I like that approach. So please keep typing in those questions, and please also note it's in the chat box. There's the website. It's Crohn's colitisfoundation.org is where you can find a lot of helpful information on Crohn's disease and ulcerative colitis and IBD. So I do want to get to some of the other questions. I'm going to reframe one of the questions that was asked a little bit. So there was a question about being diagnosed with melanoma and having to stop an anti-TNF medication, which is something we know that there's an association between anti-TNF medications and melanoma risk. But now there's a concern about the new treatment, not working. And I think rather than maybe talk about how we would approach that specific situation, I think there's an opportunity here potentially to discuss why something isn't working and maybe readdress what the risk-benefit situation is with either the current medical therapy or the next medication therapy that might need to be considered. So how would you recommend that situation is approached? Say this is happening right now and the patient wants to make their doctor concerned that their new treatment may not be working.
Wonderful. Again, it goes back to the third type of clinic visit that we talked about, medication failure or relapsing disease. So at that point, you want to come up again, revisit your treatment options. Say like, I had this one, I was on anti-TNF, but this was the concern. Now this is not working for me. And the goals can change. If you were worried about melanoma, and then that's something but you recognize that that's something can be prevented. So you can it's okay. We can talk about that. Of course, there are things about whenever you want to go back on a medication or change medications, your doctor really needs to talk about risk and benefits with it. And you should always ask about the risk and benefit too. But that is an example of like the third type of visit. I mentioned. It's okay to revisit your goals. The goals can change. The treatment options can change. And it's great. Be open to that and have that discussion with your doctor. Just kept it very general for that.
No, that's a fantastic answer. But I think the key there is exactly that. You bring up the concern that the treatment isn't working and readdress, the risks and benefits of any treatment going forward. There's a really nice question in here specifically focused, as the caregiver role. So I know you made a very good point about how we want to hear from patients as much as possible. And I agree with that, although we all agree that that's not to say there certainly isn't a role for caregivers, support people, obviously in that care relationship. So in your mind, what advice would you give to, a caregiver on the best way that they can maybe help, a patient have this very positive doctor-patient relationship?
I feel like I sound like a broken record. Communication, effective communication. And it's important to really explore that with your patients. At the end of the visit, did I answer all the questions? And how would you like to do things differently? It's okay. Sometimes it's important to ask about, do you like, what we discussed? Is there anything you want me to do differently? So I would ask sometimes the patients, like if I feel like the patients have a lot of questions or maybe the questions were not answered the way they wanted to answer, I ask them, what else can we do? How can we approach this problem differently? It's okay. You can ask the same question about asking, because the question was about what's the best way I can help the team. I think that's what the question you're reading, Dr. Dueker. And the team starts with the patient. So we can ask the patient, we can ask the other team members, what are their thoughts? We would be surprised by just how much information we can get by asking questions, because people sometimes don't share their thoughts. So if we actually open the platform by asking the different team members what they want, we can really get a lot of good information from them. Personally, the way I try to have an effective team is like work on communication, but also really want to circle back. So get constant feedback to make sure things are doing okay. That's my first advice. And we don't do that enough. We're not really asking for feedback as much as we should.
Yeah, that's a very good point. And, the only thing I would add is that I think, a caregiver, an advocate can actually probably help a patient actually prepare for an appointment, and maybe help them go through some of these pre-appointment checklists and really, collect thoughts, or during an appointment to say, encourage, like, did you want to bring up surgery? When we were talking before the appointment, you mentioned something about a different medicine or a sexual issue or something, and maybe just encourage that to come up, because sometimes, like you said, maybe patients don't want to bring it up, and a caregiver can kind of kind of say, well, the patient's driving the conversation, but the caregiver saying, did you want to talk about this, and allow that window to be open. So, I think those are both very good. Really, I wanted to, it's the question is specifically about when is it safe to get a shingles vaccine, but I think that kind of goes back to, in general, some of the preventative health issues. So I was hoping you could comment a little bit just on the role of non-live vaccines, either in IBD or in the setting of IBD therapy, and their safety and those sorts of things.
They're safe. As I mentioned, Shingrix is a safe medication. You can absolutely get your Shingrix vaccination. I know also the question was about the infusions every 4 weeks to get this yeah, it's absolutely safe to get the vaccine. No problem. You can get the vaccine without every issue. Yes, absolutely.
Yeah, and I don't think the timing matters either. You don't have to necessarily space that away from an infusion or anything like that. The only thing I'd recommend is sometimes spacing it a couple of days away from any particular infusion, because you don't want a reaction to the vaccine to necessarily be something that may have occurred, near the infusion. So other than spacing them out so we know what is maybe what in terms of a potential reaction, it's thought to be a safe and effective, all the inactivated vaccines, even if you're on immunosuppressive therapy, to get them. And I would go ahead and get that. You can discuss it with your physician, of course, your treating physician, but in general, I completely agree. It's okay to go ahead and get those vaccines. The inactivated ones, the non-live vaccines, those are trickier on immunosuppression. So but luckily most vaccines are inactivated, at least, which is good. Excellent. I do want to be mindful of time. I think the other question that I had is, I wanted to stress, is what types of things are sort of more appropriate, maybe for patient portal messaging, or sort of patient messaging through whatever EMR, that's electronic medical record, you use. Or what are things that are better with like a phone call directly to the office and things like that? Do you have a general sense of that?
So it varies doctor to doctor's office. So that's why I said, ask your, what's the best way? Do you think like, what are the type of symptoms that I should message you, and ask about the time that it takes your provider to get back to you. Of course, if they say phone calls, anything that is more urgent. So the red flag symptoms that I wanted you to discuss with your doctor, if anything is red flag, if they tell you that phone calls are better because they get a faster response, by all means, please call them. But if it's more like a general question, you can wait 3 or 4 days, and they tell you usually, if you give me a patient portal message, I get back to you within 3 days, then do that. So based on how urgently you want to hear the response, so go with the portal, that the mode of communication that are recommended for you based on the time of response. But also, if it's alarming feature, please call usually. And if you don't hear back and you're worried, it's fine. You can always, call the hotline that they have, so you don't need to do the direct. So some centers, they can actually reach out any physician that is on call. And ultimately, if you are worried about your health, it's okay to go to the emergency department. But I want to make sure that you feel comfortable knowing that how you can get a hold of your doctor, and then set that goal and when you are during the visit, before you leave the office, and have those questions answered.
Yeah, that's great advice, and I completely agree that anything that's super urgent should be, more of a phone call, just so that it's more, addressed right away. And I think it's okay to ask your physician team how our message is handled. Who sees them? Is it a nurse? Is it a nurse practitioner or physician assistant? Is it the physician themselves? It's different in every practice, and I think as a patient, just being aware of where those messages go and who sees them and who's all part of the team that's reading them or responding can be very helpful, because you may want to say something like, I would really appreciate if this is reviewed by the physician or by my care team, et cetera, versus an issue that maybe is something that can be addressed by, the office staff or a nurse that is of their level of training to be able to address your question without involving the physician. But again, knowing what messaging means and where it goes and who's going to respond and in what interval, I think is very appropriate. But also just, readdressing that urgent things, really, probably even in 2023, where there's texting and computers, sometimes just a good old-fashioned phone call is a really great thing. Well, I think that's good. I do, again, I want to be respectful of everybody's time, but there's just still many good questions. Maybe this is a good one to kind of end on. It might kind of wrap everything up. There was a question about how long do you need to stay on a medication, be it for Crohn's or IBD, before you know it's working. But I was hoping to actually mold that question into more of, how do you know if a treatment is working? What are your thoughts on how a physician and a patient should talk about, you talked a lot about treatment goals. There's things like treat to target. What's your general approach to that, so that you can maybe share with our audience the types of questions they should be asking or the types of answers they should be getting from their care team about that?
Absolutely. So I think it's a great question. And as part of the treatment goal, when I mentioned that one of the things that your physician really wants is make sure the inflammation is healed. There are different ways we can verify that. The most common way is actually endoscopically. So we can do a colonoscopy or upper endoscopy, depending where your disease is, and visualize if that inflammation is gone. So that's what essentially the gold standard would be. And ultimately, sometimes some physicians, they want to know, based on your disease progress, they want to actually do biopsies and look at it under the microscope. But that's a goal that you set up with them. And again, you're empowered by knowing the next steps. You start the treatment. The question was like, how long should I know if my medication is working if I have CD? You ask that question. So you've already talked about your treatment option. Your goal is, your physician most likely really wants to know that the inflammation is gone. So, and that's the plan. So your treatment goal is already, we know that, for instance, we talked about endoscopic remission, or we talked about other methods of indirectly looking at inflammation, stool studies. If your fecal calprotectin was really elevated, now it's really coming down, that's a measurement that we can follow to see if you're responding to your treatment or not. Particular symptoms, if you've had bloody diarrhea, really bad urgency, some of them may resolve, but again, no, as I mentioned, sometimes even though you have symptoms, you may not have active disease. Your medication may be treating the Crohn's disease, but is not the right medication to treat the gut-brain axis dysregulation. So talking about those goals, setting those goals, and understanding the symptoms is important. So mention that during your visits, and then have clear next steps available to you.
Yeah, excellent summary. Make sure that you and your doctor understand what the goals are, both to feel better and some sort of target for remission, be it stool tests, an endoscopic test, a biopsy, and you're right, that can vary a little bit. I think a standard at this point is that endoscopic remission is definitely, and that just means that you're looking with the scope and things look okay. But there are subtleties and nuances to this that I think may be more complicated than I know it's complicated for physicians, so it's presumably complicated for the patients that are trying to manage this disease on their own, in terms of what qualifies as remission and all these scoring systems and things. So again, but knowing about what those things are, and really knowing that your physician team, your IBD team, should be able to explain to you what remission means to them, but also that you can communicate what remission means to you. I think that is a really great way to come together and understand, how we're treating this together as a team. So, so with that, it's actually 6 minutes past. Again, I just wanted to thank everyone for being here. I wanted to thank Dr. Ghaffari for an excellent presentation, and thanks to Eric and Kelly for introducing and hosting this wonderful event. Again, Crohn's Colitis Foundation.org is the website. It's in the chat for any more information. And this session is being recorded, and it will be available in about a week on that website for future reference if you want to watch it again or refer it to anyone else. So with that, good night, everybody, and we hope to see you at future educational events. And thanks everyone for their time and a great session tonight.
Good night.